The talk today is on neurophysiologic monitoring being essential to discriminating between benign and potentially pathological embolization, detection and prevention during cardiac surgery. This is based on Dr. Sahig's and Daniel's extensive work in this arena. Dr. Sahig, graduating from the Sarajevo Medical School, has put a lot of focus in her career on brain and spinal cord neuroprotection using multimodality monitoring. Real expertise in there, and together with Daniel are presenting an extremely important topic, the role of neurology in general for procedures outside of neurology, and the ability to make sure that you're using those technologies to be protecting the neural system for anything that else is being done to the patient is critically important. With that, I welcome Dr. Sahig and Daniel for your presentation. Thank you so much.
Thank you very much. Can you hear me well?
Perfect.
Or I should use my headphones. Perfect. Good afternoon. It is my great pleasure to present again at ASN Biweekly webinar. We presented last year at the same time. We will share with you today interesting cardiac surgery cases where we used TCD technology as part of our intraoperative multimodality neuromonitoring algorithm. Case presentations are prepared by myself and my colleague Daniel Adams. Surgical procedures were performed by our department chair of cardiac surgery at Virginia Commonwealth University Health System, Dr. Vigneshwar Kasarajan. Pediatric cardiac surgery cases performed by Dr. Thomas Ye. We have no financial disclosure or conflict of interest with the presented material in this presentation. I will start today's presentation with historical case published in the Journal of Thoracic and Cardiovascular Surgery in August 2003 with title Rapid Recognition and Treatment of Cerebral Air Embolism, the Role of Neuromonitoring. I'm opening my talk with this case to show that multimodality neuromonitoring was in practice many years ago. Under guidance of Dr. Harvey Edmonds, we are lucky to have him online today, at University of Louisville in Kentucky. I was lucky to be part of his team beginning late 90s. Over the past years at VCU Health System, we modernized and created a cutting-edge technology in cardiac surgery, multimodality neuromonitoring. This was a 27-month-old boy with an unbalanced atrioventricular canal, hypoplastic left ventricle and dominant right ventricle, and hypoplastic aortic arch. Patient underwent the Norwood procedure at 5 days of age, one, if not most complex procedure in congenital heart surgery. Procedure was performed by Dr. Tom Ye and Dr. Earl Austin. So I mentioned we monitored several modalities for this case, and I will start with TCD. On this slide, changes in the right middle cerebral artery flow velocity spectrum are associated with air embolism on picture A, and its successful treatment on the following pictures. So we noticed a sudden appearance of high-intensity transient signals, white full-scale vertical deflections, suggestive of gas bubbles. On picture B, a transient loss of flow velocity signal occurred during hypothermic circulatory arrest. Establishment of retrograde cerebral perfusion through superior vena cava was documented by a low velocity signal of opposite direction below the baseline. On picture C, this retrograde flow is shown, and signal has been inverted to facilitate automatic velocity measurement and trending. And finally, picture D shows resolution after removal of cerebral air. Effective pulsatile antegrade flow was restored. Next modality monitored was EEG. We pulled only 2 channels from each hemisphere. So initially, symmetric pre-installed pattern was disrupted, and with high frequency activity that coincided with appearance of ultrasonographic evidence of gaseous emboli in the flow velocity spectrum shown in previous slide. Rapid cooling was performed to 26 degrees Celsius for neuroprotection, suppressed synaptic activity, and produced a near flatline EEG. New EEG asymmetry was noted during rewarming phase. Both amplitude and median frequency in the right hemisphere waveforms were decreased. This was associated with oxygen imbalance in the right hemisphere that I will show in the next slide. The following day, restoration of symmetric high-frequency EEG activity has occurred. Finally, third modality for this case were near-infrared spectroscopy modality. On this slide are presented changes in regional cerebral oxygen saturation associated with air embolization and its correction. Thick line denotes the value from the right frontal cortex, and the thin line represents the value from the left frontal cortex. Later, note the transient decline in both hemispheres accompanying embolization. As a result of our intervention, deep cooling was performed, and subsequent hyperoxia occurred with flow restoration and cold suppressed brain. The later asymmetry suggested oxygen imbalance in the right frontal cortex during rewarming phase, detected also in EEG recording presented on previous slide. In summary, this case illustrates the key role played by multimodality neuromonitoring in injury prevention. Intervention provided by the monitoring array promptly detected a physiologic imbalance, determined its probable cause, and objectively assessed immediate patient response to corrective actions. The case details suggest that as a result of this specialized monitoring, a serious neurologic complication might have been averted. Postoperatively, patient was extubated in the operating room, awake, found to have moderate weakness on the left extremities. This completely resolved next morning. Patient was released from the hospital on the 3rd postoperative day. Now I will continue with more recent surgical cases performed at VCU Health System. We will present cardiac cases where air emboli are instantly detected and successfully eliminated, with patients' good postoperative neurological outcome. First case is a 3-month-old female patient, weight 6.2 kilos, height 58.7 centimeters. Patient came in with diagnosis of tetralogy of Fallot in fundibular hypoplasia with severe valvular pulmonary stenosis. Normal size branch pulmonary arteries, normal SVC, IVC, pulmonary veins and coronaries, and right aortic arch with common brachiocephalic trunk. Surgery performed was tetralogy of fellow repair, valve sparing with main pulmonary artery, and infundibular patch performed by Dr. Thomas Ye. First slide are pre-incision EEG and evoked potential baselines collected on Cadwell Pro 32 neuromonitoring system with imported live video of TCD and NIRS in real-time recordings transmitted through specialized video sources. Baselines consist of 8-channel EEG, upper and lower SCPs, brainstem auditory evoked responses, bilateral transcranial Doppler for left and right middle cerebral artery, and bilateral cerebral near-infrared spectroscopy. All these baselines were within normal limits, as well as vital signs at the baselines. So on this slide, we are transitioning to the bypass and starting moderate cooling to 30 degrees Celsius. All signals remain stable. The decreased pulsatility on TCD is expected to be seen with transitioning to bypass pump. Vitals remain stable. Now, suddenly, we are starting to notice on TCD appearance of air emboli. At the same time, EEG and cortical SCPs diminished and bears became delayed. Now, that was partly due to moderate cooling, but we assume this was also combined with appearance of air emboli. Vitals remain stable. And this is bigger picture of transcranial Doppler and near-infrared spectroscopy. So on TCD now we are seeing a blast of emboli and asymmetry in near-infrared spectroscopy with numbers dropping over the left frontal cortex. This is a picture of tubing malfunction that was causing air leak and emboli. These emboli were not detected by the pump filter. They were detected first by TCD on time and prevented probably bigger problems for this patient. So now I will start the video. The video lasts several minutes. It shows it is recorded on DWL Doppler Box X system. It presents this whole event of emboli detection, identification, and elimination of the source from a loose perfusion connection that actually led to a change of our entire perfusion practice. It was not detected by conventional monitoring, not detected by air detectors on the perfusion circuit, and would have been missed if neuromonitoring were not in use. Uncorrected major emboli will lead to a drop of NIRS and subsequent EEG flattening and possible neurological injury. So now I will start this video. We are on bypass. Cross clamp is applied, so flow from the middle cerebral artery is non-pulsatile. Suddenly, single air emboli appear. With time, these intensify to so-called shower, and then to so-called spurt. Now the whole OR team is alerted to initiate a search for the source. At this point, emboli are turning into so-called blast, with the whole screen turning on. With the rapid search, the perfusionist working really fast to fix the problem. And they're, I think, today online with us so they can give more information. So now we are waiting for this final tightening. Where pump flow will be reduced. Just few more emboli going through with this temporarily tightening. And here is a reduction of the flow for final tightening. Source of emboli has been eliminated, so procedure can be continued safely. This slide is a screenshot right after alarm resolution, after tubing malfunction was discovered and changed. On TCD, emboli are eliminated, EEG returns to normal baselines, and nears becoming more symmetrical. Vitals remain stable. Now I will hand off the presentation to my colleague Daniel Adams to present several cases from our neuromonitoring collection. Go ahead, Dan.
Great. Thank you, Aida. The second case I will be presenting is a 75-year-old male patient with a diagnosis of ascending aortic aneurysm and 3-vessel coronary calcification. The surgical procedure performed by Dr. Kasarajan at VCU Medical Center was an ascending aorta and root replacement, valve sparing, and cabbage using deep hypothermic circulatory arrest. For those unfamiliar with deep hypothermic circulatory arrest, it is part of the cardiac procedure where the bypass pump is either minimally decreased or completely turned off for major corrective repair. Prior to circulatory arrest, the patient is cooled to a deep hypothermic state of 24 degrees Celsius or lower. This technique is required for easier surgical access and allows for a total bloodless field for complex repair of the aorta. In this case, it is important to note the special technique that was used was antegrade selective cerebral perfusion via the innominate artery. This screen recording of the procedure is showing 3 separate modalities, including the 8-channel EEG, bilateral TCD from the left and right middle cerebral arteries showing stable non-pulsatile flow, and the bilateral cerebral near-infrared spectroscopy, or NIRS, during the use of antegrade selective cerebral perfusion. In this recording, you will not be able to hear the sound of the TCD because it is recorded from our Cadwell neurophysiological monitoring system. So as we start the recording, we see low flow bilaterally on the TCD due to the selective cerebral perfusion, and then begin to detect intermittent single air emboli. As soon as we observe the air emboli on the TCD, the team begins to actively identify the potential source. So, following the appearance of air emboli on TCD, we then see a sudden change on our EEG, starting with a buildup of faster frequencies that evolve into this seizure-like activity seen in the left cerebral hemisphere. Through rapid detection, this activity was treated and eliminated by administering doses of both Versed and Keppra by the VCU cardiac anesthesia team. By this time, it was determined by the perfusion team the source of emboli was in a pump line and immediately eliminated. Our guidelines and protocol dictate that if we observe simultaneous changes in 2 or more modalities independently, our team must act immediately. As Aida noted in the previous case, if uncorrected, major embolic events have the potential to cause severe neurologic injury to the patient. This screenshot is displaying all of the modalities we utilize when monitoring cardiothoracic surgery. At this moment in the procedure, a blast of emboli was detected on the bilateral TCD, triggering the seizure-like activity detected on EEG several seconds after the appearance of the air emboli. These alerts were followed by a simultaneous asymmetry observed between the left and right cerebral oximetry values. It is important to note that during the detection and identification of these intraoperative alerts, there were no changes to the patient's hemodynamic status, nor was there air emboli detected on the bypass pump filters. Additionally, the cortical somatosensory evoked potentials shown here appear very noisy at this time. These disorganized and unreliable signals may be related to the seizure-like activity seen on EEG because comparatively, the brainstem auditory evoked potentials and subcortical SSEPs shown here remain stable and unchanged compared to the baselines displayed in the teal color. The density spectral array, or DSA summary shown here, pinpoints the exact moment seizure-like activity was observed on EEG. Initially, there was a buildup of fast frequency activity over the left centrotemporal cortical region on the EEG, seen here, which then generalized a few seconds later, shown here. Here, as we return to this previous recording and fast forward a little bit, we see full resolution of the air emboli on TCD and the seizure-like activity that generalized on the EEG. At this point in the procedure, the patient remains at 24 degrees Celsius with ongoing antegrade selective cerebral perfusion. The surgeon has been reassured by the neuromonitoring team that the EEG has returned to pre-incision baselines and the air emboli has been fully eliminated from the brain. Now, all of the neuromonitoring signals have returned within baselines as antegrade cerebral perfusion continues during aortic graft application. As you can see, the seizure-like activity has been fully eliminated on EEG. The non-pulsatile TCD remains clear of emboli. The cerebral nears have normalized back within baseline values, baseline in green, current value in white, and the somatosensory and brainstem auditory evoked potentials have returned within pre-incision baselines. Our next case is a 68-year-old female patient with a diagnosis of ascending aortic aneurysm, aortic arch aneurysm, and penetrating atherosclerotic ulcer. The procedure performed by Dr. Kasarajan was an ascending aortic aneurysm repair and total arch repair under deep hypothermic circulatory arrest. We presented this same case last year in November of 22 to explain how TCD technology can be used intraoperatively to navigate antegrade selective cerebral perfusion and deep hypothermic circulatory arrest. We did not present the embolic alert at that time because it was not in the scope of the presentation to guide adequate selective cerebral perfusion. This year, we will present the appearance of air emboli detected through the use of intraoperative TCD. I will now present another blast of air emboli captured on our intraoperative TCD on the DWL system while insunating the bilateral middle cerebral arteries. So as we begin the video, non-pulsatile flow bilaterally, and then a very dramatic blast of emboli seen. Through the use of our external TCD speaker, we immediately notified the perfusion team in the room, who were then able to quickly eliminate the source of air, which was in the perfusion line. Just some intermittent single emboli hits. near full resolution. At the onset of antegrade selective cerebral perfusion, we can confirm adequate perfusion to the brain, in this case via the extracranial internal carotid arteries. This slide is demonstrating how TCD technology is used in combination with the Cadwell Cascade Pro neurophysiologic monitoring system using intraoperative EEG, somatosensory evoked potentials, brainstem auditory evoked potentials, and cerebral Near's oximetry. It is important to note that when only the brain is being perfused and air emboli is present, there is a very short window of time to react because the air emboli is isolated only to the brain circulation. This is the start of antegrade selective cerebral perfusion, displaying a bigger screenshot from the previous slide. The surgical and perfusion teams have induced a deliberate low core temperature of 28.7 degrees Celsius with corresponding metabolic and signal suppression. The bilateral cerebral Nears on the right-hand side have increased from their baseline values in green due to a decrease in metabolic demand from the brain. This is a screenshot from the previous clip showing a blast of air emboli at the onset of antegrade selective cerebral perfusion during circulatory arrest. We can see how this blast of emboli affected brain oxygenation with a decrease in cerebral Near's oximetry greater in the right frontal cortex compared to the left. At this point in the procedure, the EEG is isoelectric during deep hypothermic circulatory arrest. And in addition, due to the deliberate hypothermic state, there is a global delay in somatosensory evoked potentials and brainstem auditory evoked responses. At this stage of the procedure, the surgical team is continuing to suture the aortic graft, and the air emboli has been fully eliminated through the adjustment of the antegrade cerebral perfusion cannula by the surgical team. The cerebral Near's oximetry has now recovered back within baselines, and the mean arterial pressure remains stable on bypass under deep hypothermic circulatory arrest. This case was a 49-year-old male with a diagnosis of previous type A aortic dissection who underwent an aortic valve resuspension, ascending aortic replacement, transverse arch replacement with frozen elephant trunk, and direct reimplantation of the innominate artery, left common carotid artery, and left subclavian arteries. In addition to this very complex procedure, a TVAR extension was also performed under deep hypothermic, under cardiopulmonary bypass with deep hypothermic circulatory arrest. So this video recording is demonstrating a shower of air emboli on bypass after the cross clamp has been removed from the aorta. So we observe pulsatile bilateral flow with the emergence of single air emboli bilaterally. The surgeon is notified and guided by both the TCD and the TEE intraoperatively, de-airing is performed by the surgeon until all of the air emboli is absorbed into the systemic circulation. Still some faint emboli, but clearing. In this case, the patient was a 54-year-old male with a diagnosis of aortic aneurysm, type A aortic dissection, and prostatic aortic valve insufficiency. The patient underwent an aortic valve replacement, ascending aortic replacement, transverse arch replacement with debranching of the innominate artery and left common carotid artery. This recording is demonstrating a shower of air emboli immediately after placement of the cross clamp on the aorta. Previously, we demonstrated the emergence of air emboli after removal of the cross clamp from the aorta. However, now we are demonstrating that air emboli can be present even after the clamp has been applied on the aorta. The air emboli is observed in the left spectral window. However, it is also observed in the M mode of the right TCD channel seen here. The only way to detect and recognize that air emboli is present is through the use of intraoperative TCD monitoring. The source of air emboli must be quickly detected by the perfusion and surgical teams. Still seeing a shower of air predominantly in the left TCD channel. And now clearing. So some of the key take-home messages we would like to share with you all today are that in cardiothoracic surgery, intraoperative TCD is the most effective modality for emboli detection. Also, spontaneous emboli can occur at any time during the cardiac procedure. Therefore, the intraoperative neuromonitoring team must be attentive to any and all changes that can occur throughout the entirety of the procedure. And intraoperative TCD should be used in combination with other neurophysiologic modalities like EEG, evoked potentials, and NIRS to distinguish between benign and pathological emboli. In conclusion, we have demonstrated how the use of multimodality intraoperative neuromonitoring during complex cardiothoracic surgery that poses elevated risks to the brain provides comprehensive neurological protection to patients. The use of intraoperative transcranial Doppler ultrasonography is the only modality that allows for quick detection of embolic events for the surgical team. Also, a team-oriented approach allows the surgical and perfusion teams to detect, intervene, and extinguish any embolic events. And lastly, unresolved and improperly treated embolic alerts and seizure-like activity on EEG, for that matter, can lead to devastating neurological outcomes. Therefore, prompt and timely interventions are crucial. We would like to thank you all, we would like to thank the VCU Adult Cardiothoracic Surgery Department, led by Dr. Vigneshwar Kasarajan, including all of the talented and dedicated cardiac anesthesiologists, perfusionists, and nurses at the VCU Health System. Once again, we'd like to emphasize a team-oriented approach with proper communication and action ensures the best possible surgical outcomes and makes cardiac neuromonitoring possible. Here are our email addresses if anyone would like to contact us directly with any questions or information regarding cardiac neuromonitoring at VCU. Thank you. Thank you, Dan.
Before we start, I will open floor for questions and discussion. Before we start questions and discussion, I would like to explain why I decided to prepare a presentation on air emboli detection during cardiac surgeries. Air emboli are almost inevitable during cardiac surgery. Question that I get from surgical teams is, if we know there will be air emboli during procedure, why perform TCD monitoring? What can be done? With today's case examples, we presented that interventions are possible. It is possible to quickly detect it, and it's crucial to save patients' brains. What amount of air emboli and do air emboli remain benign, we determine by using multimodality monitoring approach, as Daniel mentioned. Thank you. If anybody has questions, please.
You can either come off of mute and ask questions directly or run them through the chat line. But thank you in the meantime to Dr. Zahik and Dan for the incredible presentation.
Thank you.
I just am wondering what is the percentage of these intraoperative monitoring that you see as being done appropriately? Is this a huge problem throughout the world, that there's a huge number that are left vulnerable without this monitoring, or is this education sort of?
So with these complex procedures, we do see it quite often, and we presented these cases to show how often we see it. It just depends, again, how malignant these are, and that's why we are comparing with other modalities. There is a separate analysis that we are working on with Dr. Ye, our surgeon, also to define what is the percentage where we see emboli and how often we react on emboli appearances alarm. And usually when what we do is we alarm surgeon and team when we are seeing a huge amount of air, especially blast, or if we see it in combination with other modalities. So as I mentioned, almost every cardiac surgery does see some air emboli, but surgeon has to go ahead and continue with procedure. On a neuromonitoring team is to define when surgical pause is necessary and what actions should be done on what side.
And I guess as I was asking that question, Dr. Miller was basically coming in with the same point. Dr. Miller, would you like to go off mute and continue that discussion?
Oh, hello, Dan, Aida, and everyone.
Hi, John.
Thanks for a wonderful presentation. I'm one of the pediatric perfusionists who's had the privilege of working with Dan and Aida on a number of these cases, and really it was sort of our first introduction into the depth and scope of multimodality neuromonitoring when we started working with them here at the Children's Hospital of Richmond at Virginia Commonwealth University Health Center, and it really was eye-opening to us how frequently these embolic events would occur. And as Aida had mentioned, as Dr. Sayek had mentioned, it's almost inevitable on most of these cardiac procedures that we're going to see some degree of embolic activity occur. And it was just really quite a stark realization how often it was occurring. But the bigger recognition was that without the benefit of multimodality neuromonitoring, these these events occur inevitably, and we would never be aware of it. And so it's a lot like driving at night without your headlights on.
Mm-hmm.
If I could give the surgical perspective on this, and I think to Dr. Fritz's point, they happen a lot. And it's a rare event that needs intervention. Most of it's just typical de-airing and stuff after cardiac surgery. But, so if you're trying to decide whether it's worth initiating a program, which is maybe the subtext underlying that discussion, it is uncommon, and this is for eliminating this rare event in a large number of patients. So programmatically, if you look at the cost of one neurologic disaster, medical legally can run into the millions and millions of dollars. More importantly, the calculus looks quite different if you're a patient on the table and someone says there's air emboli happening. Do you want to know about them or not? for everyone in this crowd, I'm quite sure you would want to know about them so the surgeon would have an opportunity to deal with it. So it is a rare event, but it's a potentially disastrous event as well. And surgery has advanced to the point that it is uncommon, thank God. But that doesn't mean it's not something that surgeons would want to know about. It's been interesting that we've implemented these programs now at several hospitals, and at first everyone's like, "Oh, it's taking time, it costs money," and 6 months into it, people are like, "I can't believe I ever did this without knowing these things." So it is a quite reproducible shift in opinion after you get some experience with it.
Ida and Dan, thank you for a very impressive series of cases. I mean, they were just beautifully done and recorded. I'm very, very impressed.
Thank you, Harvey. It means you're a good teacher.
Thank you. I just have one question, and it kind of relates to I'm sure there's still some naysayers out there, and that is, are you aware of a published case report anywhere that described the kind of changes to both transcranial Doppler and neurophysiological monitoring that you all interpreted as a impending catastrophe and responded? They saw similar changes but did not respond, and yet the patient recovered uneventfully. Are you aware of such a case anywhere?
Not really in this setting, and that's why we are really proposing this kind of monitoring, because the only way to prove, and unfortunately we do have catastrophic cases where intervention was not possible, such as a rupture of aortic aneurysm. So the changes in EEG were, matching the changes on MRI and CTs. Today, we did not present those cases. We presented only cases with a good neurological outcome. However, I think it's on us still, Harvey, to present more of these examples where we see multimodality changes. And again, as you mentioned many years ago in your articles, it's unfortunately it is impossible to prove that this patient would not have neurological bad outcome if we didn't react.
Yeah.
So if you remember, we said we will react. There is, nothing bad to react if you find the source, if you know what the problem is, and that remains our policies and guidelines to do this.
Thank you.
Dr. Sayek, we have a question from Dr. Haddix. Thank you for a wonderful and informative presentation. Do you see any role for neuroprotective measures other than cooling, such as neuroprotective drugs, for example?
Yes. So the first case example, and Dr. Yates, our surgeon, would be the best person to explain that what surgeon can do on his end. So historical case was his case, and Dr. Edmonds was on that with us. What Dr. Yates did, and it was truly historical, because when we noticed that huge blast, it was, just described in the literature, and Dr. Yates performed retrograde brain perfusion, as I described in the beginning, and that whole air was pushed out of the brain to the systemic circulation, and the patient had good outcome. Again, as Harvey asked, would patient have good outcome if we didn't react? We don't know, but this patient had some left side weakness that resolved next morning. The other case was actually, something that we could also prevent. Now, with a huge air pharmacological protection has not been proven. We still, especially Dr. Kravchuk, I think, is with us online. They still do preoperative pharmacological protection of the brain with fosphenytoin in Louisville, Kentucky, for the patients, especially if they had previous strokes or they have intentions to do and perform circulatory arrest. So that would be pre-treatment for and protection for the brain. We would love to do studies on that. We do have intentions to do it. Harvey, maybe you can comment. We did had good experience, and we did publish, I think in '98, that we had good results with treatment of fosphenytoin and dose of steroids.
Yeah, and I also do recall one case where we identified what appeared to be a massive gas embolization, and there were complexities that prevented the retrograde perfusion. And although we did use some of the neuroprotective agents, it's hard to claim that they by themselves were beneficial. The patient awoke with a neurodeficit, and at that time the patient was taken to the hyperbaric chamber, and after a number of hours, and the patient eventually recovered. So, but that's an N of one, but it was certainly thought-provoking, if nothing else.
Yes, I remember. It was a teenager, actually.
Yeah.
And he recovered within 5 or 6 hours in the hyperbaric chamber.
Yeah.
Dr. Sharapour asks if there's any way to differentiate air embolism from plaque-related embolism.
So plaque is really a big problem. We did not present plaque obstruction today. It does happen. Those are much more difficult situations, but it's still good to know that it happened. So those patients can be sent either for neurosurgical treatment for thrombotic material extraction. I do remember, again, historical cases that had that kind of intervention. But they usually do have either permanent neurological deficit or they do die. So those are devastating, really. But unfortunately, they happen with calcified aortic material being released into the cerebral circulation.
There also is, in response to that question, there also is some difference in the acoustic signature of purely gaseous emboli and those that are particulate. What gets to be a little bit complicated is if you have a lipid-covered bubble, then that can make it a little more complicated. But if it's a pure gas emboli, they're very reflective, and so that produces those gigantic full-scale spikes. Where if it's purely particulate and with no gas involved, then most of those tend to stay within the flow velocity spectrum of the TCD signal. So it looks like a bunch of golf balls or something within that spectrum, and it makes a different kind of sound because of that. So there is the opportunity to tell if it's one or the other or a combination of both.
Thank you. I have to wonder, as representing the ASN, what role the ASN can play in helping to address this situation. And part of it is the situation a matter of of education? Is it a matter of certification? Is it where we need to create more capacity or resources in the hospital to be able to allow more of these types of studies to be done? We have a new journal coming out. We have advocacy through the AMA. We have renewed approaches towards educating at medical school and residency levels. We're increasingly providing education inside of other organizations like the Neurocritical Care Society, like the NeuroNet Pro outpatient sector. Are there any of these or different types of programs that you can imagine the ASN doing to help further this message?
That's why we are here. We are trying to share these experiences. It is hard to to decide where to start, really. But we do have to start somewhere, and this kind of presentations are great to have opportunity to share our experiences. We do have students at VCU for neuromonitoring, resident anesthesia residents, surgical residents that join us. What we do is we share our screen actually on in the operating room, big screens, so everybody can see our signals. My big desire for many years would be to have neuromonitoring recordings as a standard information for the operating room, to have it available for everybody and share if there is changes in the cerebral flow, oxygenation, how it's affecting nerve function. And I can tell you the team becomes so dependent seeing those signals displayed on the OR monitors that if it's not there, if we have connection problem or cable problem, they start looking for it. So we are trying to have some education at VCU, and we welcome everybody who is interested. We will share our presentations with ASN, and also I recently became a member of Congenital Heart Surgical Society, where we will try to establish some kind of programs and information especially for surgeons, to understand how programs can be established and be useful. And maybe Dr. Ye can tell us a little bit about it, how we can connect with ASN.
Well, your education here is really important, and its reach is through people that are looking to create other connections to further the messaging of neuroimaging in general. So you're motivating us to try to find a way that we then use our connections. And it may be that we develop a position statement like we have done before in some other areas and have co-signatures with some of the main surgical societies. But those ideas I welcome from this team because this is so important. We'd like to make sure that ASN is here for these types of purposes.
Thank you.
It looks like I've got one more question that came in the chat line, if you wouldn't mind. I know we're at we got 1 minute, so I guess I'll go ahead and ask, are you using any AI algorithms to differentiate between error and plaque, or is AI in any way helpful?
Right. All right. So AI, very in right now. We started this project with Dr. Tom Ye and our perfusionist, and we have been cooperating with our engineering team to develop some kind of software base that could be used as a start of artificial intelligence, where the signals would be combined and would be easier to interpret and alert surgical teams. There is still a long way, but at least we did start that.
Thank you. And Dr. Ho, thank you for that question. We are at 1 o'clock and we need to be respectful of everyone's time in the clinic. On behalf of ASN and all of the attendees here today, Dr. Sayek and Daniel, thank you so much for a fantastic presentation and discussion.
Thank you for having us.
Thank you, Dr. Fritz.
Thank you so much.